All right, myocardial infarction. So this is a continuation of step 7 for 12 lead EKG interpretation. All right, so myocardial infarctions. Quite simply put, it is a blockage of a coronary artery that deprives the heart muscle of oxygen. The primary causes of this can be either the classic, which is going to be a clot blocks one of the coronary arteries at a narrowing, and that can be your arteriosclerosis, things like that. Or your second one could be more of your transient scenario here, which would be a vasospasm at a narrowing. So if you think about that patient who's got a 90% blockage on a good day, and then for whatever reason that artery winds up spasming and tightening down, it doesn't take much to put that 90% down to 100%, and there's no flow through that artery. In those situations with the vasospasm, for that period of time, it'll look just like an MI because you're depriving that cardiac muscle of oxygen. So that's also one of the reasons why stress tests work. Get them there, get the heart stressing, get it moving, tightens things down, stresses an already narrowed vessel. It can, for the period of activity, create changes in an EKG, or in this case the radionucleotides, changes in uptake, oxygenation, and metabolism that show up. That being said, how exactly does all this work? Well, when you lose oxygen, your metabolism changes to anaerobic, because remember, normally we're aerobic, and that we need that O2 to do a proper metabolism. What happens is if you don't have oxygen, that means you're not going to be able to generate the energy necessary to move your sodium and potassium back and forth, which leads to repolarization problems. And when you have repolarization problems, what do those look like? Well, they look like predictable changes on the ECG, ST elevation, ST depression, things of that nature. Flipped T waves. What's really, really cool is then if you use a 12 lead, it can actually point us in the right direction for which artery has been occluded. And we'll get into that part next. That's one of the big focuses of this next section. What's really helpful with knowing which arteries occluded is it can help you prepare for interventions. So if you're going to do a PCI, percutaneous coronary intervention, you will know who needs a stent or a balloon, or both. The doc would know which artery to focus on for that activity. Also helps you prepare for complications, things like, VTAC, VFib, AFib, etc. AV blocks. Because remember, different sections of the heart are fed by different arteries. When certain arteries are affected, you may see certain types of arrhythmias sprout up as a watershed part of that event. What's really important is, regardless of whether it's a vasospasm or an actual blocked artery, you will probably see the exact same symptoms. Which brings us to the next part. Early in my career, no one really sat down and explained this to me, and if they did during nursing school, I sure as heck wasn't paying attention because I didn't know I was going to be a cardiac nurse. Well, I want to take the time now to just really point out what the big differences are between a non-STEMI and a STEMI. And if you already know this, I guess you can just move along and pick up at the next slide. But the idea is this. At the end of the day, whether you're having a STEMI or a non-STEMI, both are going to start with acute coronary syndrome. So you're going to have the chest pain, maybe that left arm pain or jaw, whichever. You'll have the nausea, maybe vomiting. You'll have the diaphoresis, things of that nature. It's gonna look the same whether it's a STEMI or a non-STEMI. And so at that point, that's why we work them up the same way. The only real big difference between them is that a non-STEMI doesn't have any changes on the EKG, whereas we'll see specific changes with a STEMI, particularly ST elevation. That really is the only difference. The rest of it is the same. Both of them, we're going to do a workup for biomarkers, troponin, we're going to look at our CKMBs, and move on down the line. The next big difference that they have is if you have a STEMI and you're showing us some really good ST elevation with symptoms, you're going to get that percutaneous coronary intervention, a stent, maybe even need a coronary artery bypass graft, a cabbage. Any one of those could come out of this, and you kind of get yourself to the front of the line when you have ST elevation. Whereas if it looks like you have a non-STEMI with no ECG changes, you may still get a PCI if your symptoms are appropriately awful, or if your biomarkers wind up trending really quickly high, or you may just wind up with medical management where we just do pills to get you through. And in both cases, you're also going to start out in the same way. You're going to do the morphine, oxygen, nitro, and aspirin as well. Those basic interventions are the same throughout. It's just really important that it's the tiniest of differences. The treatments are the same. I guess I'll go back. And yes, there is some mortality differences for these, and depending on which source you look at, there's some variations, but all in all, non-STEMIs tend to do better than STEMIs. Other topics, other catchphrases you may hear is, the patient having a full thickness or a transmural MI, or a partial thickness, which is also known as subendocardial. And this picture really just does sum up the difference between the two. I think it also helps point out the gravity of each, one versus the other, in that anytime, so for all intents and purposes, we'll say that the black here, the black is dead tissue. That's infarcted tissue, it's dead. Dead tissue doesn't conduct electricity. It doesn't move, it doesn't contract either. It's just there. It usually winds up being kind of this fibrous scar tissue. When you have that scar tissue, what happens is that part of the heart's not moving. And in a subendocardial, that's not awful. There's just a small section. You still have some good muscle out here that's able to move. It's just been hampered. Whereas if you wind up with a full thickness MI, the amount of territory that winds up being affected is huge. And I mean, look at how much of that heart wall is, for all intents and purposes, ineffective. It's going to be scar tissue. It's not going to move. You're going to lose your ability to contract well. You're going to lose your relaxation, your conduction. All of those are going to be thrown off. And so these full thickness ones have real high risk of turning into full-blown heart failure. And that's just where your heart's not strong enough to work, and creates probably one of my favorite phrases, which is cardiac cripple. And a cardiac cripple is the idea that they may look just fine on the outside, but internally enough of their heart has been destroyed that it can't function well enough for that person to have any sort of activity. That's to walk the short distances, all those things that their heart just can't keep up with their needs. The only other things that I would add, just to kind of look through this, we're going to dig into this with some more detail, but this would be one, ischemia. This would be 2, injury, and this would be 3, infarct. With your partial thicknesses, and most MIs will probably start here, and if the occlusion is large enough, goes on long enough, it'll eventually turn into a transmural if left unattended. So you can also think of these subendocardials as producing your ST depression and T wave inversions. Whereas your full thickness ones here will be your ST elevations. And then depending on how large the infarct becomes, you'll start seeing Q waves, which represent dead tissue. This is just a breakdown of what I had alluded to before. I do want to make a comment about ischemia and injury. It looks like some of the more recent literature's just kind of grouping these together as ischemia for simplicity's sake, so that it's ischemia and infarct, which makes sense because this is reversible for the most part, whereas this is permanent. All in all, it's shades of gray, and I'm going to kick back to the previous one that, even though we have these zones marked out, it's like all things. It's almost like with strokes in the penumbra. There's that just zone of where things are not going well. And then there's the zone where things are absolutely, truly dead. And that would be about all I have to mention on that. So, breaking these down, looking at them in great detail. We have ischemia, and so this is kind of number one. And yes, I realize I just earlier said that we're grouping these together, but I want to take a little bit of time and pick them apart for concept purposes. Zone 1 is ischemia, so it's the earliest stages. And yes, I know my handwriting's awful, I apologize. And what occurs is in this zone, through here where the ischemia is occurring, the tissue becomes more negative due to the hypoxia, and that creates your ST depression and inverted T waves. So if you look at the way the EKG looks over here, and I'm going to draw our isoelectric line right here, and here's where our isoelectric line should be, through here, so that you have definite ST depression as well as your flipped T wave that has now gone below. So if you see something like that, again in 2 contiguous leads, that's a sign that there is ischemia going on in that section of the heart. Zone number 2, which is injury, is so early to mid during this whole occlusion process. And yes, we're referring to a blockage in the artery. When I'm talking about this blockage or any kind of injuries, things along this nature, just assume that it's a regular MI with a clot in an artery. Now this area here, because, and I'm going to divvy these out, and so you have your zone of ischemia on the outer parts, but that injury is towards the centermost. So you can assume that in these ischemia zones, you're seeing a PQRS with depression and a flipped T wave. So you have ST depression through these parts, whereas in the injury zone, because we're not repolarizing correctly due to lack of oxygen, that area remains more positive. And so as I draw my isoelectric line across here, you have ST elevation as well as flipped T waves. It's important to note that this is measured in millimeters. So when you're reporting to physicians or things, you can say that it's, got a 3 millimeter ST elevation in lead, whatever you may be looking at. So finally, zone 3 is infarction. And so this is a late stage. So this MI has been going on for a while, well over, depending on the situation, but over an hour or more. That tissue's been starved of oxygen long enough that it's starting to die off completely. And so we have dead tissue. Now what happens is dead tissue doesn't generate any electricity at all. It's electrically neutral, and so it just doesn't conduct anything. In fact, it's in the way of electrical flow. And so as I divvy these parts out with your infarct, your injury, and ischemia, your ischemia will have that ST depression and then inverted T waves. Your injury will have ST elevation with inverted T waves, and then your infarct will do something unique. And I'm going to do our isoelectric line across here again, just so you can see it. That in your infarct section, you'll still have ST elevation because that tissue is still dead and dying. It's having a hard time surviving. But what starts happening is rather than your ST elevation getting worse or higher, you wind up with Q waves instead. Now, they're not always present because it does take a fair amount of time for enough cells to die to present Q waves. But when those occur, particularly in a situation where you see ST elevation and flipped T waves, that's a sign that that's a active, progressive, evolving infarct, and that it's continuing to change. Q waves, they're tricky. I don't know a more simple way to put it than that. They're difficult for a variety of reasons. If you look them up and read into them, there's a lot of caveats. The particularly difficult is trying to figure out if it's pathologic or non-pathologic. And that's a real art. So the most general concepts I want you guys to take away when it comes to Q waves is what I have here. And it's this, that a pathologic Q wave will be broad and it will be deep. So that it'll be wider than 0.03 seconds, which is about 1 small square. And then it'll be 1/3 the height of the R wave, which is a little difficult to conceptualize until you see it and practice it. The other things I will mention is any Q waves in V2 are worth looking into. That one really should never have Q waves present in it. Or if you have a QS shape, so it would look like this. So you'd have a P wave, QS, T wave, or even worse, actually. Let's scratch that one. If you have P, QS with an inverted T, that's pathologic as well, and that's definitely worth digging into, a QS wave. Another section or another set of things to think about is if you have any of the following in 2 continuous leads or 2 contiguous leads. It's that you'll have that broad and deep Q wave. If you have that in a couple leads, that's a sign that there may be a active or past MI. And that's where you get that thing where people are like, oh, doc told me I had a heart attack. I never knew I had one. They're probably seeing Q waves on their EKG. That's a sign of a previous MI being present. Because those will hang around forever because you'll have that dead tissue in your heart, that scar tissue, forever. Also, if you have QS in any of these leads, that's also disconcerting and totally worth a look. And if you take this knowledge here and look at what a normal QRS or a normal 12 lead looks like, if in 1, 2, AVL, AVF, oh, sorry, I forgot to lowercase that, or V4 through V6, if you're seeing any QS waves in those areas, probably a real good sign that there's something wrong going on, particularly if you overlap it with the symptoms. Other things worth noting, patients who have an MI with Q waves, they have a higher incidence of mortality, increase in amount of dead tissue, and more likelihood of having a CHF or heart failure develop out of that. Without aggressive treatment, a small infarct can become a big one. So seeing that there are new Q waves, I'll add that to here, new, is something that's always worth digging into. All right, so this is probably one of my next favorite diagrams of all time. I think it encapsulates the progression of a infarction better than I've ever seen one done. And the idea is this. So you have a normal, and we'll just say this is in the 2 lead because everyone's used to looking at the 2 lead, right? So the 2 lead will show a normal QRS right here. And then what happens is as you progress through stage 1, stage 2, and stage 3, those infarction, or as you progress towards infarction, you will see the same EKG change in that lead. And so you'll notice how we have flipped T waves. And that flipped T wave will actually progress throughout. And you can even see how the shape of it changes a little as time goes. Additionally, you'll see that as we move towards ischemia in this area here, that you start seeing ST elevation. And I'll just kind of drop through here. So we have deeper T wave, and then here we start seeing ST elevation with that T wave. And that elevation is going to continue to progressively get higher as things get worse. And you can see now we're in the full injury zone. When we start moving from injury to infarction, you'll see how your Q wave begins to develop now. And that Q wave begins to get larger rather than your ST elevation becoming bigger. And it's that trade-off that as the tissue dies, rather than becoming more elevated, it actually just becomes neutral tissue instead. And so that you wind up with this, this large and pathological Q wave when you finally reach that infarction zone. Keep in mind that the damage is going to be reversible. Maybe even up to this level here, but change my color real quick. That from here probably through to about here, we'll have reversible changes. because you're just starting to get a Q wave now, but it's tiny, it's early. There's a chance that we can overcome that. And so getting that, PCI done will help fix things. That's where you can come into that classic time is muscle. The sooner we can identify and correct these things, the sooner we can prevent permanent damage like an infarction from occurring. The other thing that I will make mention of before I progress will be that you can have, rather than ST elevation initially in this normal state to ischemia, you may get your ST depression with flipped T waves instead. But then that ST depression will still give way to ST elevation in time. Alright, so this one here, I'm going to try and pick a color that'll stand out a little bit. Yeah, we'll stick with our red. It's been working so far, right? So this is a 12 lead. And of course down here at the bottom you'd have the 2 lead going the whole length of it. But this is the regions of the heart as laid out on a 12 lead EKG. And to touch on things, so we'll start here. We'll say V1 and V2 are septal, so that's that front center of the heart. You have V3 and V4 as your anterior sections. And now we can talk about continuous leads or contiguous leads, the ones that are next to each other. So that if I had changes in, V2 and V3, even though one is septal and one is anterior, that's not to say that they're separate. In fact, we would just call that an anterioseptal MI, or whatever the situation may be. So keep in mind that this is a bit of a blurred line, that it can include multiple leads even though it's centered over one location. You've got your V5, V6, and 1, because remember V6 and lead 1 are almost identical. And as well as AVL to a certain extent are all lateral leads. They all look at that left side of the heart. So if I see changes in these two, I should likely see some change in AVL and lead 1 also. Rounding things out, we have our 2 lead, 3 lead, and AVF. And those represent that inferior portion of the heart. So if I see changes in those, then that's the section of the heart I have there. So coronary arteries. Take the previous slide plus all the other knowledge that we've gone over, and now we can apply it to real life, which is figuring out which coronary artery has been affected by the MI based on what changes we've seen in those leads. Now I know it's not listed here specifically, but I'll remind you that that septal is V1 through V2. And that is the left anterior descending for the anterior 2/3 of the heart of the septum, that's your LAD, and the posterior 1/3 is going to be fed by the RCA in most people. So if we're having changes in our V1 and V2 that make us think it's septal, we may have either one of those arteries affected. The nice thing is that will spill over into other areas, because let's take a look here at our anterior wall. I'm going to change our colors to this. So if I have changes in V1 through V4, all those cover this area right here. And so that's going to be your LAD. Now, if I have changes in the contiguous leads 1, AVL 5 and 6, V5, V6, that's likely to be a lateral MI, and most likely due to either a portion of the LAD or the left circumflex artery that are involved there. Finally, if we are seeing changes in 2, 3, or AVF, which represents the inferior portion of the heart, we're going to be looking at the RCA. And that makes sense, right? That the RCA, so we have our LCX, LAD, all those different arteries feed those different regions, and accordingly those leads will change if there's a blockage in those arteries. Reciprocals. Reciprocals. So this part's a bit challenging. I wish this had been better explained to me early on looking at these 12 leads. So I'm going to do my best to try and make sense out of it for you guys so that when I make reference to it, you can kind of put it all together. So the idea of a reciprocal change is that if you have two electrodes looking at the same MI from opposite angles, you should see basically the other side of the coin, so to speak. It works best if the leads are exactly 180 degrees from each other, but that doesn't truly happen with the way these are laid out, so you get as close as possible. And you can even look at your handout a little bit. We want to try and stick to the same planes if at all possible, but again, that doesn't always work perfect either. But if you think about your AVF, who's going to be most opposite of that one? Well, that's probably going to be something like your AVL, or your lead 1, because those are the two furthest away. So if you have, AVF and 3, the two that are furthest away from that in the opposite direction are going to be AVL and lead 1. Those would be the most opposite, so therefore those would show reciprocal changes the best. Challenging idea. As I walk through this, I'm actually going to give you the shortcuts to know which leads you should look at for reciprocal changes. Last bit, and this is a neat concept, is that reciprocal changes may actually show up before the true problem arises. And so the idea is this, that you may see, so in an inferior MI, right, inferior stuff, and I'll go back. So inferior wall, we're going to see changes in 2, 3, and AVF. So let's say ST elevation in 2, 3, AVF, right? Before that really shows up on my EKG, especially if the patient got there quickly, we would actually early on see ST depression in leads 1 and AVL. And so it's this neat concept of when you see that ST depression, that the problem may not actually be in the leads you're looking at, but could be coming in the near future from other ones. And I'll walk through some of the fine points of that. So broken down, I went through and just talked about the most common types of MIs and just tried to get them into sections for you. So anterior MIs. The direct changes you're going to see for an anterior MI is you're going to see ST elevation, and of course you'll have the inverted T waves in the precordial leads, the pectoral leads, the chest leads, all those different names. If it is a true anterior MI where the entire left coronary artery has been occluded, also known as a widowmaker, you will see changes in all 6 of those precordial leads. Whereas if you're only seeing changes in V1 and V2, that's an anterioseptal MI. Anterior and septum, both in there. If you have changes in V3 and V4, that's known as an anterioapical. Because remember, the heart is an upside down triangle with the base here and the apex here. So anterioapical. Your reciprocal changes for these cases, you're going to see ST depression, and your T waves may act a little bit funny. You may see ST depression with upright T waves. That's one of the really good signs that this is probably a reciprocal change. It's going to be in 2, 3, and AVF. Those are the most opposite of your chest leads that we can get. They're also looking at that area of the heart from the most opposite angle that we can have, which is why you would expect to see those changes there. A little bit difficult of a concept, but just trust me. So reciprocal changes, 2, 3, and AVF for anterior MIs. And it should be the same amount, just a different angle. So if you have a ST elevation of 3 millimeters in V3, V4, you should see ST depression of about 3 millimeters as well in those leads. That's the general concept. Lateral MIs. So that's going to be that far side of the part of the heart on the left side. You will see your ST elevation with inverted T waves in those lateral leads. And so an anterolateral would include V5, V6, and you would see similar changes in 1 and AVL. So anterolateral, it's encasing that entire chunk because the 5 lead does include part of the anterior of the heart. A true lateral MI, which is going to be your left circumflex, is pretty much only going to show major changes in your 1 and AVL. And again, those put you in the same territory so that the physician would know if we're having any kind of a lateral MI, that's going to be a left coronary artery issue. And now he just has to decide, he or she have to decide if it's the LAD or LCX that needs to be stented. Your reciprocals for a lateral MI are actually your 2, 3, and AVF again, because those are measuring at the furthest or most opposite distance of these leads, of the lateral leads. And you may even see those ST depressions in V1 and V2. And if you really think about the way they're splayed out across the chest, V1 is one of the most opposite leads from V6. V6. Inferior MIs are a little more tricky, but the concept is this. We have direct measurement through your 2, 3, and AVF. Again, inferior, that's what you would expect, right? You'll see the ST elevation and inverted T waves. And this is with the standard EKG. If you see evidence of an inferior MI, that is absolutely 100% appropriate to then get a right-sided EKG. A little unique, some of you may have never heard of it before, but the idea is, and this picture here shows it, that instead of running your stickers across here, as in with a standard, you run them the same pattern on the right side of the chest rather than the left. And these two leads here, V3R and V4R, R standing for right, if you see ST elevations in those, you definitely have a inferior MI, for sure, hands down. Your reciprocal changes for a standard EKG will have ST depression in the most opposite leads you can find, and so that will be 1 and AVL, as discussed before. You may even see some of those changes in V1 and V2. This becomes a bit of a challenge, and we'll talk about it a bit in the next slide too, is that the reciprocal change of ST depression in V1 and V2 may be for an inferior MI or could potentially be because of a posterior or a posterior lateral MI. And if you think about it, V1 and V2 are right there in the center of the chest. So if there's an MI going on in the back side of the heart on the opposite side, that lead may not be able to won't be able to see it directly, but will be seeing it from the opposite side. So V1 and V2 ST depression can oftentimes be a sign of a posterior MI. And this is one of the reasons why we dig into this whole reciprocal discussion, is that if you understand that seeing ST depression can be a sign that there's ST elevation somewhere else, potentially, it'll help you dig into those things. And even more so, if you see ST elevation in V1 and V2, that could potentially be a late sign of a posterior MI that's really gotten out of hand. So as we move to the next slide, how do we verify a posterior MI, particularly given that we have these challenges with not being able to see the front, or not being able to see the back of the heart? Well, if you have any signs of an inferior MI, you really need to consider getting a posterior MI or posterior MI workup as well. And what that includes is something called a posterior EKG. EKG, where you have your standard layout. So here's 1, 2, 3, and then you have 4, 5, and 6, right where they would normally be, but you get 7, 8, and 9 on that back side of the heart. And what that allows is us to directly measure the posterior side of the heart. And so if we see ST elevation in any of these 3 leads, and again, has to be contiguous, you've got yourself a posterior MI. And then to follow up on the reciprocal discussion, if you see ST depression, V1 through V3, because those are on the opposite side of the heart where the MI is actually occurring, makes sense. Depression on the reciprocal side, elevation on the direct side, which is why you have that. Okay, so that wraps up all of this discussion and explanation. Next step is going to be going through a whole bunch of examples, and we'll pick up there next.